questions for the end if we have time. I'd like to invite our next speaker, Professor Parijat Chandra from RP Center, who will sort of take the journey now of the 30 years of what's changed in treatment ideologies and modalities in ROP, whom, when, and how to treat ROP.
Honor again to speak in this session. Thank you, Professor Azad. Thank you, the panelists. So I will talk about who, when, and how to treat ROP and what changed in 30 years. So when I started as a resident at RP Center, the first thing which I saw in the OT was I saw Professor Azad doing cryotherapy, in a child. There was a big, commotion in the OT, and a lot of anesthetists were there, pediatricians were there, and cryo was being done for a very small baby. So cryotherapy was a very popular modality of treatment for a very long time. Also the multi-trial cryotherapy therapy also came in. And cryotherapy stood the test of time for a very long time. However, the problem was you needed GA. The child used to become sick after cryotherapy. And a lot of painful spots were given in this eye. And gradually it was replaced by laser. And laser then became the gold standard of treatment. The early treatment ROP trial has stood the test of time, and a lot of us still follow the ET ROP trial results which came out, and it advised type 1 and type 2 ROP, and type 1 ROP, which is marked by the red, is where commonly treatment is advised by laser for ROP. And this was typically how laser principle was applied, that you have avascular retina, you treat the avascular retina, and the disease will tend to go away. This article was written by some of the experts which you see also sitting here, and it advised good advice of how to treat with laser in these eyes. The problem basically was how to laser in aggressive ROP. A newcomer coming into ROP just didn't understand where is the ridge, where should I laser in this case. So we showed by angiography in some of these cases that the blue line is actually where the newcomer will think that he has to laser, but actually red line is where he needs to laser, because the whole area in between is just avascular loops, and the disease will progress if you do not laser in this area. Posterior barrage laser again became very popular along these years. Many people like to do posterior barrage laser in the hope of avoiding surgery, or in the criteria that there's some posterior vascular areas. And many of these cases, posterior laser did work very well in selected cases. Although in this particular photo, it's a little smaller zone. In a more anterior zone, posterior laser barrage will work very nicely in some selected cases and not in all cases. So this is typically how laser regressed zone 1 aggressive ROP used to look like, and someone has put in a lot of hard work to do laser in these cases. But the problem right now in this is that it leads to limited visual field, poor macular perfusion, and the risk of high myopia is obviously there. So what has changed across these years which has brought better treatment modalities in zone 1 ROP? So anti-VEGFs emerged over the last decade as the first line of treatment for zone 1, zone 2 posterior ROP, and it allowed for rapid ROP regression in these areas. And the huge benefit which it had was retinal revascularization, which laser could never do, allowing for a better visual field, better foveal structure, lesser refractive changes, and obviously it was a much faster, more convenient procedure to do for the surgeon and the baby as well, with less pain and a more stable baby. More and more regulatory approval has happened over the years, with ranibizumab getting approval from the European Union and aflibercept from the US FDA. And some of the current usage scenarios of anti-VEGFs, has already been pointed out earlier, is that if you have a pupil like this which is not dilating, a lot of neovascularization is there, you give an injection in 3 days, this is how it dilates. So very good response is observed upon injection, and then you can do laser surgery or whatever you want in these eyes. So this is a magic drug in that way, that just has a wow factor when you inject it. A lot of the challenges with laser, like where to laser, this is case of zone 1 aggressive ROP. Again, you see that the macula is not vascularized. Where should I laser? How much to laser? So in these cases, again, anti-VEGF worked very well. So I'm just trying to show you here a case where a very small amount of posterior zone is here, and what to do in this. If you laser, you have to come in very close to this. However, if you inject this case, the the retina will continue to grow. So you don't stop it. You let it grow as much as it can, and then you can go ahead and do a combined treatment. In fact, now we are combining threshold laser also in some of the cases with anti-VEGF and laser. And sometimes if you've got a very bad ridge, it might sometimes lead to better outcomes if you combine the both. And because the laser is going to take time and the anti-VEGF is going to work very quickly. So however, some challenges are there. So which drugs to use? Because a lot of drugs are now available in the market. Biosimilars are available in the market. So we've been using biosimilar because in the government hospital supply for the last 2 years, ranibizumab is there with us. So there's no financial interest. But it has got similar results of earlier Lucentis, which we used to use. A lot of other biosimilars also now available in the market. People like to use half the dose, and although some of them like to use ultra low doses, 1/4 dose, 1/8 dose. But as you reduce the dose, it becomes more and more difficult to measure. And usually one injection works very well in these cases. I'm just quoting the study which was done by the IROP Society. A survey was done where they tried to show the common practices of ROP specialists, 157 of them, and they found that most commonly bevacizumab was being used half the dose. They like to do it in the OT, and they like to do it simultaneously in both the eyes. So injection-related complications are there because people are doing it in the ICU without proper sterile measures. And proper aseptic techniques. So you can have cataract and endophthalmitis. A lot of these cases are now coming up. So you have to be careful about that. Reactivation is a huge problem with anti-VEGF. So in around 6 to 12 weeks, the disease tends to come back. So you have to be careful about that. Keep a close follow-up, and if it comes back, you can do laser treatment and then do it. Obviously, it's been reported very well that ranibizumab has a faster and more reactivation than aflibercept and bevacizumab. And as Dr. Anand was also pointing out earlier, there's, managing power is a very important thing. Don't let the baby go away. A large amount of peripheral vascular retina, if left behind, needs to be treated so that the disease does not reactivate later and has later peripheral retinal changes. A lot of systemic concerns have been reported by many authors, and however, the level of evidence right now is low and the benefit is huge, so we continue to use these anti-VEGFs. And I think this is what is going to happen in the future. Some telescreening model robot is going to go do a screening, and then the AI model is going to tell you, which case needs laser, which case needs to be injected. So this is what is happening, and this is what is going to happen in the future in the next coming few years, that the robots and the AI is going to guide you what is to be done, and this is going to be very exciting in the future, what's going to happen. The last frontier is ROP surgery. In these cases, again, the disease advanced beyond a particular level and retinal detachment is happening. So scleral buckling was done in a lot of cases across the last 30 years. And now the indications have reduced as MIVS has become more popular. But still, a lot of people like to do scleral buckling in some particular indications. For example, you see the photo on the left side where stage 4B sequelae is developing in the periphery. You will not be able to relieve it effectively with an MIVS. So possibly a buckle applied on that side, some people might like to do. This case came to the right side. He had forceps delivery, subluxated lens, a large break with the RD. So again, buckling might be a better option than just doing surgery like that. For MIVS, early intervention is the key. You should go in when the TRD is low. Low TRD, less peripheral TRD is there. Macula can be spared, and there can be less new vascular changes. So here you can do it, lens sparing surgery, easy instrument access, good traction relief can be done. When you are here, it's already too late. And we like to do bilateral surgery if both eyes are progressing simultaneously. It allows for single exposure to high-risk GA. Obviously, patient counseling is important and it needs to be like 2 different surgeries. Basic principles are same. You need to do centripetal, vertical, circumferential traction relief. This is again the same case which I showed you just now. This is a 25G lens sparing vitrectomy happening. So you need to take care of this traction which is happening. Relieve this traction which is going to later cause the fold here in the retina. Relieve all the traction which is there over the TRD so that this can fall back. Don't worry about the bleeders because they can be dithermized and it can be taken care of there. And that's how you want to relieve all these 3 kind of tractions. And if you do good surgery, then the TRD is going to fall back and the traction can be very effectively relieved. Sometimes we like to combine anti-VEGF with surgery. And this kind of outcome can be only obtained when you combine both of them, especially in particularly selected cases. This is not recommended for all cases where you have a progressive TRD. You see extensive neovascularization is there on the left side. And it's already progressing despite laser. So if you combine both of them, you see such a clean outcome being obtained, which cannot be obtained just by surgery alone. Stage 5 ROP surgery, my teacher and mentor, Professor Azad, trained me in a lot of these cases, and I'm very thankful to him. And he used to deal with a lot of these cases, and as he's highlighted, the lack of screening is the major important cause. And a lot of these are, medical legal cases because ROP screening has not been done in these cases. And Dr. Benekar has this whole series where he will, if you read it, you'll have an idea what happened in this. And so basically, this is how I like to do it. This 23G MVR is going in through which 25G instruments go in through a clear corneal approach. And now we're going to do lensectomy here so that all this can be relieved. This is the retinal membrane. You go in an area where the lenses, where the retina is not attached in those areas. You can go ahead, continue to dissect, create bigger and bigger openings there. So the idea is most of these babies are left for blind. So it's better to go in and operate these babies in the hope of getting some kind of navigable vision. And as you see, as you continue to dissect into the posterior part, you can see the disc is there, the posterior pole is very shallow detached. And this is how the surgery would look like in the end in a sutureless manner. And just to conclude, so over the 30 years, what is still the best way to deal with ROP over these last 30 years is to prevent ROP. and the ROP is generated in the NICU. If you follow good NICU practices, then ROP will not develop, and even if it develops, it will develop to a very limited degree which can be easily managed with laser, and that is the way to go. To prevent ROP is the way to go in the future. Thank you so much.